a very long, great, fruitful life, full of very positive. He is a professor of neonatal medicine at the University of Child Health Science and Children's Hospital, Lahore. Professor Hakki is a fellow of the Royal College of London, Edinburgh, Ireland, College of Pediatrics and Child Health, United Kingdom. He has over 54 years of pediatric and neonatology experience working in Asia, Arabia, North America, Canada, and United Kingdom. He has published over 200 peer-reviewed papers, 6 chapters authorized. Actually, we are very excited to hear a very unique lecture about understanding physiology of postnatal transition in preterm infant and golden hours. The floor is yours, Dr. Khaled.
Thank you, inshallah. Can you see my slides, and can you hear me? Can
yes.
You see? Yes. Bismillah.
Yes, Dr. Khaled.
Okay. Bismillah ar-Rahman ar-Rahim. Thank you yourself and Professor Tawfiq for inviting me for this Congress, and I send you greetings from San Francisco. I'm very, very grateful for this invitation. I'm surprised that my talk was put in the endocrine session, but let me take you back to the delivery room, where I would like to talk about the understanding the physiological basis of the golden minute and the golden hour in resuscitation of the very preterm infants. Now, why should one talk about this, and why should one actually deal with this subject? The importance of this subject is really that even today, in September 2023, nearly 1 million babies die annually on the day of their birth, and that constitutes nearly 40% of neonatal mortality. So it is not surprising that it is said that one is never closer to death than on the day of their birth. And you can see how majority of neonatal mortality occurs within the first 24 hours of birth. And that is why it is important to talk about this subject. I have no conflict of interest and nothing to declare. The objectives of my talk are, I'll give you a little bit of background on what initiates the baby breathing, a basic physiology, and I apologize for the senior members of the audience who know all this, but I think it's nice to be able to refresh one's knowledge. Then I'll talk about transition from fluid-filled to air-filled lungs, and then give you the essentials of what we now consider the golden minute and extended it to the golden hour. And lastly, and 2 slides on the practice point and where we are and where we are going. So one important fact which we all know and should remember, that the baby in utero is not pink. The baby in utero is purple and has a saturation between 50 and 65% with a high pulmonary resistance and low cardiac output. What happens during transition is this baby has to move from being purple to being pink in whatever time we think is appropriate, and move the saturations from 50 to 65 to over approximately 90%. But this must be accompanied with a fall in pulmonary resistance and increased cardiac output. Now, normally, in term infants, 90% of term infants, this happens automatically. Only 5 to 10% of term infants require a little bit of stimulation. And about 3 to 6% of term infants require some degree of basic resuscitation like bag and mask. But that is not so with extremely preterm infants, where majority may require basic resuscitation. And advanced resuscitation is required in less than 1% in term infants, but about 10 to 15% in the very preterm infants. And that is why it is important to discuss this particular subject. Now, depending on what we do with these infants at birth and at the time of their birth, it is important because not only it's a matter of their life and death, whether they will survive or they will not, but it is also that it might affect the whole of their life because of comorbidity. And despite advances in neonatal resuscitation related to perinatal events have not really substantially changed in the very extremely low birth weight infants. And thus, the golden minute and the golden hour are recognized as the most important period in one's life. And understanding its physiology is mandatory for all those who care for babies and who attend deliveries in the delivery room. So just a couple of slides to refresh your memory as to what are the essentials. The crucial event during transition is lung aeration. So the lung has to change from liquid filled to air filled, and how does that happen? For this to happen, the newborn requires neuronal and muscular components of the respiratory system must be present. And what are they? There should be enough neurons, there should be a respiratory drive in the pons, there should be neuromodulators controlling the respiratory rate so that the baby can breathe at a particular rate. There should be chemoreceptors to prevent the overall stretching, and there should be functional phrenic nerve and a diaphragm to make sure that the baby is breathing. The other fact, which is important to remember, is that fetus actually starts intermittent breathing from the 15th week of gestation, about once or twice a day, and then gradually increasing. But during parturition, that is, during the process of birth, breathing is inhibited due to the increase in placental prostaglandins. After birth, breathing becomes continuous in most infants, but not in all. Why doesn't it happen in all babies, particularly in the extremely low birth weight infants? They fail to establish sustainable and efficient breathing due to a very strong Herringbrough inhibitory reflex, the softness of the thoracic cage, which gives them when they try to breathe, the cage sinks in, and the weakness of the respiratory muscle. But the strong Herringbrough reflex is when they try to breathe and the lungs are stretched, which they are not used to in stretching in utero. This stress, since the stress receptors send a message via vagus nerve to stop stretching the lungs and stop inspiration. This increases the expiration, and then baby stops breathing. That's what happens during parturition. And the chemoreceptors then start the activity again, and this keeps going round and round in circle. So the first message I want to give based on physiology is when you try and resuscitate a baby, excessive stretching of the lungs inhibits breathing. So avoid high peak inspiratory pressure and avoid high peak end expiratory pressure during resuscitation. The second and a very, very important point is neonates need a baseline carbon dioxide level, which is around 6 kilopascals or 40 millimeters for respiratory activity. But if the CO2 level falls below the baseline, breathing ceases again, apnea occurs. And the threshold is very low, this difference is very little. The threshold is around less than 37 millimeters. So from 40 to 37, just a fall of 3 centimeters of CO2 will inhibit breathing. And this threshold, because if we tend to give hyperventilate these babies bag and mask at a rapid rate or give a high tidal volume or high inspiratory pressure, then this will induce apnea. So the second very important point during resuscitation is high tidal volumes, high pressures or rates may actually push down or cause apnea. So we have two main reasons which we can avoid. One is not to stretch the lungs too much, and two, not to increase the rate, resuscitate with increasing the rate at such a rate that the CO2 level falls and the baby becomes apneic. And as I said, the most important element is to go from a fluid-filled lung to an air-filled lung, because that is what changes the pulmonary resistance, and that is what increases the cardiac output. And this is done in 3 phases, which occur simultaneously. Labor induces cortisol and epinephrine release and vasopressin, which increases the fluid reabsorption. The lymphatics work over time, and as the lung expands, the fluid goes through the lymphatics, absorption is greater. The alveolar stretch secondary to gas exchange and release of surfactant compresses the blood vessels and pushes the interstitial fluid out. And this process starts just at the onset of labor. And so if you deliver a baby by C-section before the onset of labor, that is why the baby's lungs are still full of fluid and you get TTN. And this process of emptying the lung can last for up to 48 hours. Now, coming back to the main topic of this talk is the golden minute and the golden hour. This is adapted from the Formula One tire changing. You see here, the car comes in and 4 tires are changed within 1.8 seconds. The reason is that we need to get the right people, be prepared, allocate the role, and work in a standardized manner with the aim of continuous improvement. So we need to have the right people, right? And they should know what they have to do. Each one should know what they have to do, and they should be doing it in a standardized manner. This was first introduced by in adults, but then adapted in neonatology, and has become standard now since Maureen Reynolds introduced it in the 60s. So what are the elements of the golden minute? 4, only 4. Cord clamping, oxygenation, establishing breathing, and circulatory support. What about cord clamping? The facts are, with physiological closure, when the cord stops pulsating itself, 40% of the fetal cardiac output is diverted to fetal vital organs within the last 30 seconds. And so it is important to remember that about 50 to 75% of blood available for transfer from placenta to the fetus occurs in the first minute. And so if you clamp the cord within the first minute, this blood transfer does not occur. Or if if you deliver the baby below the placenta, then there will be more blood flowing in to the baby. But if you have the baby up above the placenta, then the reverse will occur. What we do know now is, with intact cord, 84% increase in chances of spontaneous breathing. So a baby who's apneic, if you don't clamp the cord, that is much better, because if you clamp the cord, the chances of baby starting to spontaneous breathing goes down even further. Now, there are 2 ways of doing it. You can clamp the cord before the onset of breathing. This restricts flow to the ventricles. Pulmonary resistance remains high. There's decrease in left ventricle preload and increase in the afterload. And if you cord the clamp after the onset of breathing, this reduces pulmonary resistance. It decreases right to left shunting through the ductus, increases left ventricular preload, and so it is much more beneficial. So now it is standard. I think everybody knows, and everyone who's practicing neonatology knows, that while it is established for term infants that cord clamping should be deferred for at least 60 to 90 seconds, that is after the first minute. But the question remains, is it also true for the very low birth weight preterm infants? Currently, it is thought to be prudent to induce breathing before clamping the cord, even in these infants, but there is no consensus, and the evidence there is not very robust. A recent paper, in fact, published earlier this month, tackled the issue, very controversial issue of cord milking. This is in non-vigorous infants, 35 to 42 weeks, about 1,700 infants, 10 countries, 10 centers, 3 countries. It showed there was no reduction in admission to the neonatal unit, no reduction in death, and no difference in requirement of fluid bolus or better absar if you milk the cord or just clamped it. But milking of the cord, reduced respiratory support, increased hemoglobin, reduced moderate to severe HIE, and the Apgar scores were a little bit better. But this needs to be confirmed, and we need to be, and there is this question whether we should be clamping these milking or not milking. That debate will continue. As I said, what is important is to get the baby breathing. And here's a video of a rabbit, actually. It shows you that the lungs have not expanded. There's hardly any pulmonary flow. And as the lungs expand, you can see there's a tremendous increase in pulmonary blood flow. So as the pulmonary resistance falls, the pulmonary blood flow increases. And there's also, at this time, reversal of right to left shunt through the ductus arteriosus and fall in systemic resistance. Now, as I said, most term babies do this by themselves. And they do this by taking a deep breath and holding it for a little while. So they increase the intake of air and they develop a functional residual capacity. But a preterm baby, extremely preterm, can only really whimper. It cannot generate that cry, it cannot generate that inflation pressure. And so the question then is, how do we help these babies? How do we help these preterm babies? Inflation breaths, or sustained breaths, as inflation as it's called, or application of CPAP. There is a tremendous transatlantic divide between the Europeans and the Americans. The European guidelines recommend 5 inflation breaths, 2 to 3 seconds each, pressures of 30 centimeters for term and near term, and 25 centimeters for preterm infants. Whereas in North America, no inflation breaths. They do not recommend inflation breaths. So what are we to do? And there is a meta-analysis by Harish Kirpalani, which showed that it favors no inflation breaths. But remember, when you read these meta-analyses, remember these black boxes, they actually show you these effect of one study on the whole meta-analysis, and you can see the weighting of this particular one single study is nearly 50%. So we need to decide whether, if you take this study away, whether this is true or not, and the Europeans continue to debate that. My personal opinion is that, as the Americans do not recommend sustained inflation, European society do. My personal feeling is that when you give inflation breath, it preferentially aerates just the apical parts of the lung and the middle part, but not the base where a lot of fluid continues to stay. So, and one of the gurus of neonatology, Keith Barrington, has written recently that I think that sustained inflation as routine initiation of resuscitation of preterm infants should be laid to rest. But that's, of course, a North American view. The European view might be very different. So what can we do, or what should we do if we don't know whether to give inflation breaths or not to give inflation breaths? Well, perhaps the better way is to have a continuous distending pressure in the lungs. So you distend the lungs and keep them distended by giving CPAP in the delivery room, which improves lung volume, recruits the alveoli, increases the ventilation perfusion matching, releases more surfactant, opens up the alveoli, as I said, decreases pulmonary vascular resistance, and stabilizes chest wall at the same time. So that has gained favor, and currently most people would, in extremely preterm infants, not give inflation breath, but put them on CPAP very early on. But the evidence shows that non-invasive compared to invasive support does not reduce death or bronchopulmonary dysplasia, but reduces IVH and moderate to severe neurodisability at 22 to 30 months, and the need for surfactant therapy. So I think there is growing evidence that perhaps rather than giving inflation or sustained breath is to give continuous positive pressure ventilation. Next debate is about oxygenation. And again, here there is a considerable amount of difference of opinion. We all know that if your mother has too much oxygen, that will affect the fetus. If the mother is hypoxic, that will affect the fetus. The fact is that fetus, as I mentioned earlier, the partial pressure is around 15 to 25 with a saturation of 50 and has got a large amount of fetal hemoglobin, which tightly binds to the oxygen and doesn't deliver it to the tissues. But the question is, baby being purple to pink, how much in a hurry should we be? How much, what is the normal time? Most babies achieve 80 saturations above 80% by 7 minutes, and that has been shown in large number of studies going back many years. I have just put down some studies from 2017, but the data is available from earlier years, and more recently data has come through which shows term infants, all infants more than 37 weeks, infants between 32 and 36 weeks, all infants less than 32 weeks, most of them achieve a saturation of 80-85% by 3 to 5 minutes. Now, why do I talk about this? But yeah, before I go to that, one of the beauties of Allah and the nature is that despite it takes longer for blood saturation, oxygen saturation to go up, the brain oxygen saturation is achieved within seconds of birth. So the brain is preferentially given more oxygen at birth. And this is even more fascinating, is that if the baby is hypoxic, the rate of cerebral oxygenation, tissue oxygenation index rises much more rapidly. And if the baby is not hypoxic, it rises gradually. And this is one can only just admire how babies try and protect their brain from hypoxia. When we give oxygen, why do we do that? Because we want to increase the heart rate, we want to induce pulmonary vasodilation, we want to prevent cerebral depression, and we want to help the lung clear fluid. But what we do forget from time to time is that antioxidative capacity in preterm infants may cause oxidative injury if we give too much oxygen. And that is one of the reasons why we continue to see ROP, BPD, NEC, and IVH. Now, as I said, there is debate. What is the debate? The debate is in a very preterm infant, whether we should start oxygen in 30%, less than 30%, 60%, or more than 60%. The evidence there is that it doesn't make any difference, no difference in mortality, short-term morbidity, or neurodevelopmental outcome, what percentage oxygen you are giving to the baby. But what is the major difference is, when does the baby achieve a saturation of 80 or more? If the baby does not achieve the saturation of 80 or more, there is increased death, increased IVH, decrease in heart rate, and cognitive scores. What we do not know is, what about areas between 30 and 60%, 30%, 40%, 45%, 50% or so. And we also do not know what the ideal saturation for less than 30-week babies are. And I've already talked about the cord clamping strategies. So what is the current consensus? It is important to select the appropriate FiO2, but we do not know what the appropriate FiO2 is, and carefully and timely titrate FiO2 up or down against saturation to avoid the extremes of hypoxia and hyperoxia and bradycardia. Oxygen delivery should be reviewed and titrated every 30 seconds. There's weak evidence for that. And just a point to remember, it takes 19 seconds for saturations to change after you've changed the FiO2. So the current recommendation is that if the baby is 29 to 34 weeks, start between 21 and 30%. If the baby is less than 28 weeks, start at 30%. If the baby is more than 35 weeks, initiate it in room air and aim to achieve your saturation within 5 minutes of 80 or more. That is the current recommendation. Circulatory support, we all know, is effective only once we have established respiration. And if you should do, if the baby requires cardiac compression, then it's only when you have established respiration. There's no point in doing cardiac respiration compression when the respiration has not been established. The other point within the first minute is to maintain, in doing all this, we must make sure that the baby does not lose temperature, because hypothermia is a risk factor for mortality. Around 28% proportion of babies who die because of hypothermia. And it may come as a surprise to you, the rate of hypothermia on admission to NICU currently in the United States varies between 31 and 78%. The reasons are very well known, the physiology, because the baby cannot shiver and there has less brown fat and glycogen. This moves into the golden hour, golden minute moves to the golden hour. The temperature control continuity we talk about, and prevention of hypoglycemia, monitoring and record keeping. Now, just 2 points I want to make here, that 4 out of 10 infants admitted to NICU are hypothermic. And if you look at in the graph, that 50% of babies of gestation of less than 30 weeks and somewhere 25 to 25 weeks die if their temperature is 36 degrees centigrade or less. So we need to make sure that there is temperature. Delivery room is not too cold. Baby maintains their temperature, provide humidity, and that's why we need. And that will be, if we don't do that, we will have lower Apgar score, more IVH, more late onset sepsis, hypoglycemia, and respiratory distress. Now, talking about hypoglycemia, again, within the golden hour, we must make sure that the baby does not become hypoglycemic, because because as soon as the cord is clamped, the placental supply of glucose ceases, and there is transient reduction in the blood glucose level, which then triggers counter-regulatory hormones, and gluconeogenesis takes place, which brings the level back to normal. So we must make sure that this transitory, we recognize this transitory hypoglycemia and make sure that this does not occur. The problem here and the controversy here is how do we define hypoglycemia? And here are the definitions provided by American Academy of Pediatrics, the American Endocrine Society, Academy of Breastfeeding, British Association of Perinatal Medicine, Canadian Pediatric Society, Swedish National Guidelines. They all differ in what they call hypoglycemia. Their levels differ. But to us who practice neonatal medicine, the usual textbook figures are either less than 36 or less than 47, but it actually makes no difference neurocognitively. And so whatever level you decide, you must make sure that the level should not fall below that, and you should correct the hypoglycemia. Wrap up now, of course, in the very advanced countries and in the advanced neonatal units, within the delivery room, immediately as the baby is born, hundreds of electrodes are put in to measure and do infrared spectrophotometry. We can do echocardiography in the delivery room. We can do electrical cardiometry to monitor hemodynamics, and of course, oxygen saturation index. Now, these are good tools to use when in a highly developed country, but it's not really something which is available to most of the world. And there was a very recent paper which compared and asked neonatologists what they think are the important variables at the time of delivery which they should monitor. And most people from even developed countries and developing countries showed that the heart rate, saturation, and temperature are the 3 things which they would like to monitor in the delivery room and continue to monitor in the neonatal unit. While in the advanced units, people said video analysis, lung aeration volume, and wireless vital signs. So their development is going in that direction. But I would suggest to you that heart rate, saturation, and temperature are the most important variables which we should be monitoring. But if nothing else you take from my presentation, and I'm sorry that it has been put between endocrine session, but if nothing else you take from my presentation, please, if you have a standardized policy, just as the Formula One people, standardized policy for how you manage the first minute of birth and the first hour of birth. They're having a standardized written protocol of practice for the golden hour leads to improved outcomes, reduces mortality, reduces hypothermia, reduces hypoglycemia, IVH, BPD, and ROP. So no matter what you do, please in your unit establish a standardized policy for the golden minute and the golden hour. And this is a quality improvement study from Canada, which showed once they did that, their outcome was much, much better. So what are the things which we need to do before birth and within the first hour of baby's birth? We should have done antenatal counseling for high-risk babies, respiratory support, cardiovascular support, prevention of hypothermia, nutritional care, feeding earlier, so preventing transient hypoglycemia, delayed cord clamping I've talked about, and of course making sure that you don't give infection to the baby, and if necessary, only when necessary, send lab works. But what is more important is to keep records of what you do and then to audit them from time to time, and that will give you a better outcome, and you will improve the survival and reduce the comorbidities of the baby. Now, this is a very complex detailed slide, but you will find it in any published data on management of the golden hour, is to determine, as I said, should be the right people they should know what they have to do, and each one has got a given task. So as long as this teamwork plays, your chances of improvement are higher. But of course, never forget that no job is finished until the paperwork is done, so that you can re-audit and try and do quality improvement studies and improve your performance. Lastly, I think what I have said is goal of oxygen therapy in preterm infants during DR is to avoid two extremes, either hypoxia or hypoxia. But unfortunately, these extreme levels are yet to be clearly defined. The current recommendation for oxygen therapy in preterm infants come from low quality evidence. Should infants less than 32 weeks start with 30% or 40% or 60% of IO2? I don't know. The best advice is to titrate it with the saturations to achieve a saturation of above 80 within 5 minutes. Pulse oximetry and oxygen blenders should be used during resuscitation of preterm infants. What we must do, these are the minimum requirements in preterm infants. Saturation above 85% must be achieved by 5 minutes after birth. Do not apply excessive inspiratory pressure or rapid respiratory rate, otherwise you'll induce apnea. Oxygen should be titrated every 30 seconds till targeted saturation of above 85 is met. Heart rate should reach 100 or more by 5 minutes after birth. Application of CPAP is better than giving inflation breath. Maintain infant's temperature between 36.5 and 37.4. I'd like to thank you for your attention, and just to give you a last message, don't be too aggressive or in a hurry during resuscitation. Just be gentle. I'm grateful, and thank you, Tawfiq, for the opportunity.
Thank you very much indeed. It was an excellent presentation. Thank you very much. Thanks. I will send you any questions by email.